What are the main reasons for using neoadjuvant therapy in melanoma? And how does it help before surgery?
So over the past couple of years, we've discovered there are many good reasons to prefer neoadjuvant therapy over just adjuvant therapy by itself. I think the pivotal trials so far have shown that, number one, we've been able to show that when we give neoadjuvant therapy, so immunotherapy, for example, when there's still tumor in place, that helps to strengthen the immune response. What basically is happening is because there's more tumor left in place at the time of administration of immunotherapy, that helps your immune system recognize more diverse, different types of cancer proteins, if you will. So if you are giving immunotherapy when there's more tumor in place, you have increased number of tumor-specific antigens that are released into the body, and that basically helps to strengthen the immune response.
How does a good pathologic response after neoadjuvant treatment predict better outcomes for melanoma patients?
So there's been a lot of really good science and a lot of interesting work that has been done to show that when we pooled data from a lot of smaller neoadjuvant trials, we were able to show that the degree of pathologic response in the surgically removed neoadjuvantly treated specimen, that correlates with recurrence-free survival. So in other words, depending on the amount of residual viable melanoma that's left in that surgical sample, that can help predict for how likely that patient is to experience recurrent disease in the future.
In trials like SWOG 1801 and NADINA, how did neoadjuvant pembrolizumab or other drugs improve survival compared to adjuvant only?
So we know that when we give adjuvant therapy after surgical resection, what current studies have shown is that it does help to decrease the risk of recurrence, but it still does remain quite likely, unfortunately, that a certain proportion of those patients will develop recurrence of their melanoma. So what the neoadjuvant trials have shown, for example, SWOG 1801, NADINA, or even if you look at the pooled data that was published from the International Neoadjuvant Melanoma Consortium by our Australian colleagues. The first author was Alex Menzies. For patients who received neoadjuvant immunotherapy, and let's say they achieved the best possible result, which is a major pathologic response, so 0% residual viable tumor, that those patients almost uniformly did very well in the long term. And by very well, I mean almost approaching 100% of those patients continue to be disease-free, even many years out from their neoadjuvant treatment.
Can neoadjuvant therapy allow for less surgery or adjuvant treatment? And what do PRADO and NADINA say about de-escalation?
Yes, such a good question and a controversial topic. I think the question really at this point has no definitive answer. I think there are certainly clues we can take away from available data. I do think that de-escalation of the surgical intervention and the adjuvant portion is possible. PRADO, for example, was able to show us that in patients who did achieve a major pathologic response, that 2 years out from that treatment, that more than 90% of those patients remain disease-free. However, I do think that the reason it's controversial is that not everyone achieves that major pathologic response. So what do you do for the patients who have achieved only a pathologic partial response or even non-response? So I do think that's definitely a little bit of a gray zone. The OPASA Neo and PRADO trials, I think, have given us clues that perhaps it is safe to de-escalate patients who have good pathologic outcomes. But I am looking forward to more data in the form of longer follow-up of the patients who participated in these trials. I think that MSLT3, which is a forthcoming surgical de-escalation trial. I believe that's going to be designed as a non-inferiority study, spearheaded by colleagues in Australia. So I think that will be a very interesting trial to look at, really trying to answer the question, is it safe for these patients to get only an index lymph node resection versus full therapeutic lymph node dissection? So I think that we've come a long way, but certainly there's still a lot we don't know. And I'm looking forward to seeing future data, future trials to help us answer those questions.
If you liked this video, you may also like this suggested video, 2025 Breast Cancer Immunotherapy Trials. Key updates from Dr. Levy from the same conference. In the description, you will find a link to a web post companion for this video on oncologytube.com. Thank you for watching.